Thank you. And we go on with John Barratt. John has visions of B cell targeting for IgA nephropathy.
Thank you. Here we go. 5 minutes I've been given. Thanks, guys. 4 minutes, okay. Right, here are my disclosures. So I'm going to come across 3 concepts that I hope we're going to discuss in the IgA group. So you've seen this, Jürgen presented this already, the new paradigm for how we should think about IgA nephropathy. And when we think about targeting B cells, what we're really, I think, thinking about is stopping that IgA immune complex accumulation within glomeruli by preventing or reducing immunoglobulin production. But actually what I hope we do get to discuss at some point is what targeting B cells within the kidneys itself might do in terms of have an efficacious signal. And Brad already showed with CAR-Ts removing B cells from the kidney tissue itself. How much is that contributing to the efficacy we see long-term in a disease like IgA nephropathy? And I think this is where the repeat kidney biopsy studies that Brad and I have been advocating continually to all the IgA nephropathy sponsors in the room, hopefully will start to give us some information. So I think hopefully this is something we will touch on in our discussions. The second thought process is how do we go about targeting immunoglobulin production in IgA? And we've come a long way. What we have, no one's mentioned at the moment, is we could target a whole immune microenvironment and in turn target B cells. And that's what the drug Nefecon does by targeting the mucosal immune system. And we know that that reduces levels of immunoglobulin. So that's an approach that can target B cells. In IgA nephropathy, we've also got approaches that are being looked at to target T cell help, which we've discussed, B cells directly, and plasma cells. And I'm not sure anyone's mentioned CD38 depletion yet, but we're certainly looking at that in IgA nephropathy, I think mentioned in the membranous talk. What's interesting about IgA is CD20 depletion doesn't seem to have any effect on the fundamental pathogenesis. No effect on Gd-IgA1, no effect on antibodies against IgA, no clinical effect, suggesting there is something fundamentally different about IgA nephropathy. And the other thing we haven't mentioned, which are the new kids on the block, are the depleters, the antibody depleters. Do we really want to be interfering with B cells if we can actually remove the antibody directly from the circulation? So we have efgartigimod, which leverages the neonatal Fc receptor, which has been shown to reduce IgG antibodies against myasthenia gravis and is now proven. That argenx has developed an IgA depleter. We have Biohaven that can specifically deplete Gd-IgA1 from the circulation. We haven't seen any data in patients yet, but that's coming. And there are protease therapies, which we've already seen in terms of IgG proteases. So might we actually be evolving away from targeting the B cell, particularly in a chronic disease like IgA nephropathy, and more safely impact on just removing the preformed antibodies? And then finally, which I think we're going to have to wrestle with a lot in our group, are what are we actually trying to achieve? So one aspect of the disease is this group of IgA molecules we collectively call Gd-IgA1 that we measure routinely in lots of different cohorts. It's always elevated in patients. What the data tells us is this is driven by a generic defect in mucosal immunity. This is not a specific clone or oligoclones of cells that are generating this. This is generated throughout the mucosal immune system. We are not going to be able to stop this from happening. We have lots of genetic data now showing us that this is a generic process through the mucosal immune system activation. So we can't deplete, we can't cure the disease by knocking out Gd-IgA1. We'd have to wipe out the whole of the mucosal immune system in every part of the body to achieve that. Is IgA nephropathy actually an autoimmune disease? And I think this is a really important question. So what evidence is there that there is oligoclonal B cell expansion and loss of tolerance? I think there's zero evidence actually at the moment. It's a hypothesis. Drugs like rituximab don't work. We've got no clear evidence that there is an autoimmune process here. What I think it may well be more likely is that actually the antibodies that recognize circulating Gd-IgA1 are IgA and IgG antibodies that are generated during the normal physiological response to bacterial infections. Because we know these antibodies are generated against cell surface glycoproteins, and the antibodies are recognizing the Gd-IgA1, those sugars at the hinge region. And if that is the case, all the things that we've been talking about, are they appropriate necessarily to manage IgA nephropathy? Are we potentially thinking about we can cure this disease? Because if we can't treat the Gd-IgA1 because it's an inherent abnormality of the mucosal immune system, genetically based, and actually the antibodies that recognize the Gd-IgA1 and drive immune complex formation are actually the antibodies we are all generating against pathogens we come across throughout our life. Have we ever going to be able to deplete all of those antibodies safely? So I think we're in a dilemma here. If it's a true autoimmune disease, everything we've been discussing is highly relevant to how we manage IgA nephropathy going forwards. If it's not, and bearing in mind IgA nephropathy is, I think, very different to many of the autoimmune diseases we're talking about today, then what should our goals of treatment be? How do we safely suppress immunoglobulins for the lifetime of a patient where actually there may not be a cure because both sides of the equation are actually continual, highly polyclonal, and actually there isn't an absolute target that we're trying to achieve to deplete completely. So I think we've got our work cut out to discuss these things. There's no clear answers at the moment. But I think for us in the IgA world, we want to put a brake on antibody production. We don't want to deplete, we don't want to deep deplete, we want to gently reduce the two components that form immune complexes in the safest possible way. And that's where I think we may well take a different approach to some of these other disease areas. So thank you very much, and I look forward to discussion.